Hello, everyone, and welcome to another day of high yield USMLE question. So today we'll be talking about GI questions. So a 65-year-old female presented with 2 months history of fatigue and yellow discoloration of the eye. So far it looks like jaundice, and there is also weight loss during this time period. And she also complains of pale stool, so it looks like obstructive. So family history is significant for hypertension and diabetes. This patient, they did not mention that this patient has it. It's just family history. Vital sign normal. Patient on examination shows there is severe icterus and labs are following. So total bilirubin is really high and direct is high. So it means the direct hyperbilirubinemia. So ALP is also through the roof, so it's really high. AST and ALT are normal. Antimitochondrial antibodies are negative, and what is the likely cause of this patient's symptoms? First is the Wilson disease, and the Wilson disease would be wrong. First, because this is a 65-year-old female. Usually, Wilson will be younger, like 17-year-old, 18-year-old, less than 30, usually less than 30 or 35. So Wilson will be wrong here. Also, there will be usually neurologic symptoms they give for Wilson. There are also KF rings, case of Fleischer rings they give on the slit lamp examination. Increased urinary copper and decreased serum ceruloplasmin. So those are the features. But here, the patient is really old, and I don't think, and the picture is obstructive jaundice. So also AST-ALT are normal. So Wilson usually affects the AST-ALT as well. So those would be the reasons that Wilson is wrong. And Wilson is genetic, right? So that's why younger patients are affected most. Then acute hepatitis is also wrong, and you can easily exclude this acute hepatitis by looking at the AST and ALT. These are normal. So remember, in acute hepatitis, they are through the roof. They are like greater than 1,000, AST and ALT. You should know, like, if ALT and AST are greater than 1,000, think about three things. On NBMEs or on USMLE. It could be acute viral hepatitis, like hepatitis A, B, C, D. Even herpes and CMV can cause acute viral hepatitis. So think about acute viral hepatitis. Second, acute ingestion of paracetamol. So that would be the second. The third is shock liver. And shock liver is just ischemia. For example, there is heart failure, there is hypovolemia, hemorrhagic shock. So that results in decreased flow to the liver and damages the liver. So here, AST-ALT normal, acute hepatitis rules out. And hemochromatosis, again, usually will affect the AST-ALT levels here. ALT-AST levels are not affected. Hemochromatosis, remember, on boards, a few high yield points are that Vibrio vulnificus infection is increased. Vibrio vulnificus, usually oyster or shellfish, those things are eaten by the patients, and then they present with hemorrhagic bouillon skin. So that's Vibrio vulnificus. Vibrio vulnificus would be associated with hemochromatosis. So and the reason for Vibrio vulnificus is that it is iron loving. So, and hemochromatosis, you get a ton of iron. So here, AST-ALT normal, so most likely hemochromatosis will not be the right choice here. Also, hemochromatosis has other features like joint pain. Those are not seen here. Malignancy. Yeah, so this one, malignancy looks like this could be it, right? There is weight loss, features suggestive of malignancy, yellow discoloration, weight loss, pale stool could be a mass obstructing the biliary tracts. So here, ALT is raised, which most likely means that it is some looks like it is mainly affecting the biliary tracts. Could be cholangiocarcinoma. So it could be any malignancy, remember. And primary biliary cholangitis is not the right answer, because they said here is that the antimitochondrial is negative. And remember, this affects intrahepatic channels, biliary ducts, intrahepatic biliary ducts. So if you have the intrahepatic, and you can remember this by females. It also affects females mostly. So females are usually like indoors, and so that's way you can just kind of remember that primary biliary cholangitis affects intrahepatic ducts. And so then let's talk about this malignancy. What could have caused that malignancy? So it could be any. So if this is if this is the liver, and this is the biliary tract, and you also have the pancreas here. Pancreas is here. And the biliary tract comes here and then empties in the duodenum. Remember, to the liver, a lot of like the pancreatic cancer can here cause obstruction and present with this feature. The GI, for example, if this is a GI tract, ascending, descending colon, remember, the most common site of metastasis for colon cancer is the liver. And if they ask you why, because all of the blood that is draining the colon is through the portal vein, and the portal vein goes to the liver. So the malignant cells, when they get injury to the blood, the first organ they encounter is the liver, because it is drained through the portal vein into the liver. So this is the first organ encounter. So liver metastasis is the number one site of metastasis for colon cancer. So here, the obstructive jaundice can also be caused by this pancreatic cancer as well. So it could be any cancer. It can also be like the cholangio, like I said, because AST really elevated. So it could be cholangiocarcinoma. Remember, one of the risk factors for cholangiocarcinoma is primary sclerosing cholangitis, which is associated with ulcerative colitis. And also, primary sclerosing cholangitis is also associated with colon cancer. So these are all high yield for Usmle, and you should absolutely know this. And if anyone requires tutoring, so you can email me here, and please like and subscribe to this channel if it helps you.